Thank you, Angela, for that introduction. So first of all, I'd like to begin that I don't have any financial disclosures, and I'd like to begin with 4 cases. So these are very common cases. It didn't take me too long to come up with these 4 cases. A 35-year-old female seen in a preoperative clinic for THBSO for ovarian cancer. She reports she had a port placed and that she became short of breath, had a rash. She was told she was allergic, but she doesn't remember what they said about what medication that she was allergic to. And she tells us that she suspects it's Versed or fentanyl. Case number 2, this is a 39-year-old female, G2P0, term pregnancy, requesting an epidural for labor pain. About 15 minutes prior to this request, she had a significant episode of fetal bradycardia associated with prolonged contractions. And everybody was suspecting that she might need to go for emergent C-section and hence may need some postoperative pain management or have some postoperative pain management issues. So when went in to see the patient, she reported she's allergic to compazine, causes anaphylaxis. Dilaudid causes tight muscles. Morphine, tight muscles also. Reglan, jitters, sulfa, rash, suprax, hives. Third patient, this is a patient who's going for a Whipple procedure. She actually was seen in our preoperative clinic. She reported to our nurse very diligently that she is allergic to lidocaine. She now comes on the day of surgery and the anesthesia team is saying, oh, now what are we going to do about postoperative pain for this patient? And then the 4th case, this is a 34-year-old female with symptomatic gallstones going for elective laparoscopic cholecystectomy. During the pre-anesthesia assessment, which was on the morning of surgery, she reported she's deathly allergic to avocados. So the anesthesiologist kind of ponders what is the impact of this food allergy. So today I'm going to talk about agents that can cause hypersensitivity reactions. I'm going to review signs, symptoms, and management of that. And then the last part is I really want to try to go over these cases to give everybody an idea of how to handle these patients in a practical manner. These are all the agents that have been listed, that as I was reviewing all the literature, you can see in big bold letters, are some of the more common agents that produce hypersensitivity reactions. Now, these adverse reactions can be due from multiple reasons. I mean, we all think as physicians allergies, so it's got to be immunological, but that's not always what we get. We have patients who are allergic to epinephrine in a dentist's office, and that's not because they have immunological reaction to the epinephrine, but because the dentist injected it intravascular and now their heart rate goes up and they don't like it. So they report to us that they're allergic to epinephrine. You can have it, like I said, immunologic. There can be variations due to the patient's metabolism or just the mode of action, and then you can also just have these bizarre idiosyncratic reactions occur. So it's really important that actually if you do have a patient who has some kind of adverse reaction, and they're going to list this as an allergy on their future surgery, that it's important to really document exactly what happened and to really talk to the patient. I wanted to present this lecture at a conference that involved a lot of internists and hospitalists, and they said, what's the big deal? What's the big deal about these patients who have allergies? You just switch to another drug. But as we all know, well, we do give a lot of medications. We are limited in what we can give our patients. The most important thing that we do need to be concerned about are these immediate hypersensitivity reactions, and those by definition occur within 1 hour of surgery of the causative agent. They can be life-threatening with mortality rates up to 9%. The incidence really varies. I read some literature said it's as common as 1 in 400, but it can go up to, it's probably more likely in that 10,000, 1 in 20,000 range. During the perioperative period or the anesthetic period, patients are exposed to multiple drugs. And it's not just drugs that we give, but also drugs that maybe the surgeon gives, maybe the nurse gives, and just also what we're wearing that can cause these reactions. The main causative agents are typically antibiotics and neuromuscular blocking agents. And there's actually a regional difference. For years I heard that it's neuromuscular blockade, but in my 4 patients who had anaphylaxis, 2 of them were antibiotics. And so it's one that there actually has been good recent literature over the past 5 years that shows that in the United States, antibiotics are probably the most likely agent, or more frequently agent, causing these immediate hypersensitivity reactions. Mechanism is that, first of all, it's a systemic reaction. This is not something very localized, it's systemic. It can be immunological. That's our typical IgE antibody, binds receptors to mast cells that cause the release of these mediators. And the most common agents that patients are exposed to in the perioperative period that cause that are antibiotics, NSAIDs, biologic agents, iodinated contrast media, latex, and foods. But you can also have IgE independent, such as IgG, that with iodinated contrast media, NSAIDs, dextrans, and then biological agents. With anaphylactic reactions, there can also be a non-immunological process, and a lot of times that's very difficult to know exactly what that mechanism is. And with opioids, cold temperature, ethanol, that's mainly direct mast cell activation, but you can also have idiopathic, such as a patient with mastocytosis. In awake patients, they usually have some kind of generalized symptom of not quite feeling well. And unfortunately, when a patient is undergoing an anesthetic, a lot of times this symptom is not there. So in anesthetized patients, these reactions are more very sudden, and they involve 3 systems: the cutaneous, cardiovascular, and respiratory. They can be in severity, going from something as mild as just having urticaria, that is grade 1, to all the way up to grade 4, which can involve cardiac or respiratory arrest. The World Allergy Organization has actually very good information on both perioperative anaphylaxis or immediate hypersensitivity reactions, and their definition of anaphylaxis, it doesn't matter whether it's IgE mediated, IgG, or non-immunologic, that basically it's all called anaphylaxis, and their criteria is any of the 2 that you need to really think that this is anaphylaxis. In our care of patients, unfortunately, there are many things that can cause symptoms that are very similar to anaphylaxis. And this is just a whole hot punch list of all of the things that can really be the real cause, but you need to keep in mind that it could potentially be anaphylaxis. Now, what about chemical markers? That tryptase is actually a very important marker that if you do have a patient who has anaphylaxis, that this is something that you really should draw. It reaches peak life within 30 minutes of reaction. Its half-life is about 90 minutes, and it can last up to 6 hours. And it's important that whenever you draw a tryptase level, that you need to get a baseline, and that typically needs to be done about 24 hours after an event, because then you can see a rise. and then a decline. Mast cells contain high levels of tryptase, and that's why that this marker is very unique for mast cell release in anaphylaxis, and that it has a very high positive predictive value, greater than 90% if it is elevated. But it is important to remember that there are several conditions in which it could be elevated and not have a patient have anaphylaxis, and that's in patients who have mastocytosis and then also acute myelocytic leukemia. What about histamine? I heard about, y'all hear about histamine release with opioids. Histamine is also released with anaphylaxis, and it reaches its peak within 5 to 10 minutes, so very fast onset. It declines within 15 to 30 minutes, and that's really the problem with drawing histamine levels. It also requires a special tube. That's too hard for me to deal with. You need to take care of the patient during this critical event, and most of the time in that first half hour, you are doing a lot to try to save the patient. So histamine levels, drawing that, really don't have a good utility clinically for us, whereas tryptase does. Now, as I said before, it's really important if you do have a patient who has anaphylaxis that you need to treat the patient. That's always number one, and early administration of epinephrine, because it can inhibit the release of mast cells, is very important. But also get a tryptase level. Remember to do that sometime within the 3-4 hour period. And then also then to repeat it 24 hours later. But I want to highlight that really I think the most important part is that that if you have a patient who has an adverse reaction, you need to be actively involved in the patient once they leave the operating room or leave your care, because other people are going to be doing the workup, and you want to make sure that things are done appropriately. And I'll mention later on in my talk that actually what we suspect might be the offending agent many times is what the offending agent is, but not always. So what do you do when you have a patient who has allergies? Well, first of all, it takes time. I always hate it in the morning when I go see a patient and they have the band that says allergy instead of the nice little band that says no known drug allergies. You need to review what these reactions are, because that's what's the most important part to determine is really what is their reaction. And then you need to review if the patient did see a specialist, such an allergist, that you need to review that data. And then if they haven't seen anybody, then maybe you should have them see an allergist. So let's go back to our cases. So this first case, she's going to have an anesthetic, we know it, and she says she's allergic to 2 drugs that we commonly give. So this is a case that you think, well, maybe we should send this patient to an allergist. And it turned out, before the patient was sent to an allergist, we actually obtained the record, which can be difficult many times, but we obtained the record, and it turned out they were actually exposed to 3 different agents. One was with a contrast agent, and then midazolam and fentanyl. Now, what does an allergist do? Well, they really need to know what the offending agents might be, and that really it makes their workup a little bit different. So if it's a neuromuscular blockade, an IV anesthetic, midazolam, propofol, colloids, dyes, then an allergist will perform a skin prick test. If it's negative, then they'll do a more sensitive intradermal test. If it's an opioid or NSAIDs, the allergist can consider skin testing, but a lot of times, because of histamine release, you can have a positive skin test but not really have the patient allergic to it. So in that case, they may consider giving an oral challenge to the patient. For antibiotics, local anesthetic and chlorhexidine, again, it's a skin prick test. If that's negative, then do intradermal test. If that's then negative, then maybe performing a drug challenge on the patient. And then lastly, with latex, that's also with the skin prick test. If that's negative, then you can get the specific IgE testing. If that's still negative, then an allergist will a lot of times perform a glove challenge, which is where you prick the skin through a glove. So for our particular patient here, the patient was sent to an allergist. Skin testing for midazolam was reported as negative. The patient had told the allergist that she's taken PO pain medicines without any problem. And based on the records, talking with the people who were involved in the original incident, that the allergist really thought that it was probably the iodinated contrast media that caused the problem and not the midazolam or fentanyl, but then they also gave the qualifier of, well, you can't always tell. So in this particular patient, the anesthetic plan was a general with a preoperative epidural, but the anesthesia team actually avoided midazolam or fentanyl, but they did give other opioids to the patient. Now, what about our emergent OB patient who might be going for a C-section? All right, so this particular patient, all right, she has multiple allergies, and I can thank Mike Wall, if any of you know him. In our preoperative clinic, we have in the back of our chair, our desk, we have a little yellow sheet of paper that gives all the most abnormal things we've ever seen in our preoperative clinic. So we have the lowest potassium, 2.0, the highest hemoglobin AC, greater than 20. And we also have one for allergies. So we had a patient who came in with 36 allergies. And this is not the only patient who has come in with that many allergies. We have had many, and most of them are the orthopedic surgery patients. They're patients who have multiple surgeries, and something always happens. And they just say, well, I'm allergic to that. I just don't like that medication. But there is such a thing as cross-reactivity. And the neuromuscular blocking agents that typically, if you're allergic to one, you might be allergic to other ones. Antibiotics, we all know the relationship between penicillin and especially first-generation cephalosporins, and then also iodinated contrast agents. So in this patient, fortunately, she said that she has never been told she's allergic to sufentanil. An epidural was placed, and we had pre-made kits with fentanyl or sufentanil, and the regular pre-made kit was done. The patient said she had tight muscles, so it's an allergy that I don't think was quite an allergy, and but certainly the patient was informed that going to give a drug similar but totally different than what she's allergic to. And fortunately, she had an uneventful delivery, and we didn't need to worry about intravenous opioids or postoperative opioids. So now the patient going for the big Whipple procedure. Now, she's allergic to lidocaine, and actually with local anesthetics, you can do a drug challenge. It can be subcutaneous. But I want to caution everybody that you just don't want to do this on anybody, that you really need to talk to the patient about it, really find out what the reaction is, and in this, you need to have resuscitation equipment available. So in this particular patient, she was elderly, and she really kind of didn't know what happened with the lidocaine. She said, I just didn't feel good with it. And fortunately, her daughter was there and said, yeah, Mom, I was there with you. It wasn't the lidocaine, and you just weren't feeling well. It's probably like a vasovagal type of reaction with it. And kind of talking over it, we decided that she probably wasn't allergic to lidocaine or local anesthetics. Gave a small dose of lidocaine subcutaneous, waited 10 minutes, and I do need to caution that you really probably should wait longer than 10 minutes. It should be more like half an hour. And an epidural was placed and general for surgery, and she ended up with no complications. And our last case, this is the patient who has a food allergy. So it is well documented and well known about latex food syndrome, that many patients who are allergic to particular foods, and these are the primary ones are banana, avocado, kiwi, and chestnut, but there are many, many others, including strawberry, which is way down the list, but there are many of these cross reactivities. The other thing I want to mention a little bit about is food. Those patients who are allergic to eggs, soy, or peanuts, that there is good literature suggesting that patients who have these allergies can be given propofol. Okay, so what a particular patient with the allergy to food. Discussed with the patient, she said actually when she wears gloves, she does get it kind of red, but she never really got the connection that maybe that could be a latex allergy. Discussed with the team, and this is actually fairly easy to just switch to a non-latex environment, and so that's what was done with this particular patient, and there were no complications. So in summary, that I've gone over a few of the scenarios that you can have of patients with allergies. It's important to get the information of whatever their reaction was, and then be aware that there are certain drugs in which you can have cross-reactivity. And if you then need to decide whether or not you're going to refer them to an allergist for skin testing, if a drug challenge is going to be done, or if you just simply avoid the drug. And lastly, this is my email address, and I know San Francisco has the Golden Gate Bridge, but and the beautiful blue Pacific Ocean, but we have the Arch and the muddy Mississippi. So thank you very much.
I'd like to welcome all speakers to our panel up here and have a seat. We'll take questions now if you have them. Please come up to the podium, up to the mic, and bring us your questions. Questions on allergy testing, allergic reactions, cardiopulmonary exercise testing.
Hello, I'm Jamie Brown with Washington University at St. Louis, future resident coming in for July. So my question is, in the setting of patients that come in through the ER, how would you feel that perioperative assessments and planning should take place in that setting? Because, I mean, a lot of times you don't have much time, and certainly may not have time to replete iron, or would that have an effect in that small time frame?
Anyone can answer that question.
There's actually some literature that people are using iron infusions intraoperatively to affect postoperative management. Not good outcome data for that yet, but I think it's intriguing and interesting because, again, it's like I think we need to think beyond the immediate perioperative period, but think long-term of how we could perhaps impact patients. And many patients who are having surgery, particularly like emergency surgery, are going to be repeaters. So they come in with their infected limb or something, and they have just a simple IND. And then, over the course of time, they have some more, and then they have their flap. So maybe sooner rather than later.
There's actually a randomized trial that I reviewed. It has been accepted out of Europe, multi-center with intravenous iron infusion. I know that it had some very positive results, so it'll be interesting to see when it is actually published.
A second question. So how do you guys view the future of postoperative management and assessment of patients after surgery? Do you feel like that would be a direction that seems very real, or do you feel like it's something that is still pretty pie in the sky?
So I'll actually comment, and we were talking, I think the postoperative surgical home will be something that disappears, or at least I hope it does, because it has disrupted incredible relationships with our colleagues in the surgical services. But I think perioperative medicine will take on greater importance. What's the difference? The difference is if we put the patient at the center of the question, of what's the best thing for the patient, and then we figure out who's the best person to take care of each part. You know, the orthopedic surgeons will say, to be honest, in our place, it's co-management. In other words, they want both the anesthesiologist and the hospitalist, and that includes post-op interventions and working together to look at that. The cardiac surgeons actually don't want the cardiologists anywhere near their patients. They actually want the cardiac anesthetists and anesthesiologists there. So it'll be very locally driven. It'll be very much relationship driven, but I think that the question that will come in the future as we talk about the patient being the center and the transfer of information, and one of my colleagues, Megan Lane Falls, in the audience, who talks about handoffs. If we can hand off the information properly, then it's hugely valuable. The issue is nobody hands off post-operative information to the primary caregiver. So I think that's going to be the area that if we take any leadership in, will be a huge difference. That's why, while I think troponins post-op would be great, until we figure out that handoff, I have my concerns.
Just thinking of your question, I recently spoke with Monty Mython from the United Kingdom, who's a member of the SPACI board and runs the EBPOM meeting, and he said it's complete. Oh, is this on? Okay. I recently spoke with Monty Mython from the United Kingdom, who's a member of the SPACI board and runs the EBPOM meeting, and he was saying in the United Kingdom it's completely different. Because of our billing system here, there's no interest in co-management. The orthopedic people take care of their patient post-operatively and have learned how to do it, because they only will call a consult when they really are looking, in trouble. So the whole system there versus here is very different, and their system works well too. So again, as Lee said, it's hands off, it's about the patient, it's what's in the best interest of the patient, but to automatically have a co-management is adding huge costs to our society and something else we have to be responsible about.
Well, actually, CMS is convinced bundles are the future. If you Republican, Democrat, whether you're a believer in the ACA, if you talk to the people in Senate Finance and in House Ways and Means, and I've talked to a lot of the staffers, and they say no matter what happens, bundles and alternative payment models will not go away. In fact, the private insurers all believe in it. So the question to your will be, if all the money goes to the hospital, then the hospital is going to see who does the best for the patient. And if you focus on, if you work together and shorten the length of stay, then you all win. And I think that's going to be the driver. I actually think bundling is going to be the driver of how we look at this. And if we go to type 3 and 4, which is population health, then the handoff will be critical. And then the question is, are you doing a post-operative evaluation because they're post-op or because it's an opportune time to actually do something that can affect long-term?
Thank you. I think we've actually reached the end of our time. If you have one more question, you can come up. If you have any questions, you can come up to our panelists individually and speak afterwards. Thank you so much for coming.